Sourav Kumar Mishra and I am a consultant in medical oncology at Apollo Cancer Center, Bhubaneshwar. Of late, immunotherapy has been a very important development in the field of cancer therapy. So immunotherapy has been in this field for quite a long time, but the contributions of immunotherapy in the improvement of outcomes in cancer patients is a recent story. So the immunotherapy, what is immunotherapy? What are the mechanisms of immunotherapy in cancer, and how immunotherapy improves the outcome in cancer patients is the topic of our discussion today. If you see about immunology, so immunology comprises of the body's own immunity. So in that we have the T cells, the B cells which are lymphocytes, and the main action of the immunity of the body is to prevent the infections. Similarly, the body's immunity also prevents the development of cancer. So if there is cancer which is developing inside the human body, it is by a mechanism of immunosuppression. So the body's immunity is suppressed by the cancer by various interactions between the cancer cells and the human body, and accordingly the cancer starts developing and finally proliferating and metastasizing. Therefore, the principle of immunotherapy is that immunotherapy boosts the body's own immunity to fight the cancer. So if we can give something to boost the body's immunity, and the suppressed immunity, if it can be provided a boost, then the cancer cells cannot survive. And this fundamental principle was discovered quite a long time back, but the clinical trials and the results are very recent. So immunotherapy is a very recent development in the field of cancer therapy. Previously, immunotherapy, like the cancer vaccines, which is also a form of immunotherapy, because if you know, immunotherapy in the form of vaccines, if you inject a vaccine, then there are body's immune cells which develop against this vaccine, against the antigen which is provided by the vaccine, and if we can inject a cancer vaccine, then there can be immunity against this cancer antigen, and this is also a form of immunotherapy. But what we are discussing today is about the monoclonal antibodies. So monoclonal antibodies are form of cancer therapy, and most of the immunotherapies are monoclonal antibodies. These molecules are developed outside the body, and these are transfused or infused into the body to fight against the cancer cells. So accordingly, the immunotherapy can be of various class of drugs. The most common immunotherapy drugs which we use in our clinical practice are the anti-PD-1, that is the programmed death receptor 1 molecule, and that is known as nivolumab and pembrolizumab. And then there are other like the anti-PD-L1, which includes the atezolizumab and durvalumab, and then there are the anti-CTLA4, which includes the ipilimumab. The most important class of drugs, this immunotherapy, they have really revolutionized the treatment in advanced cancers, especially the renal cell cancers, the lung cancers, and the melanomas. So initial therapy with immunotherapy had the most beneficial effect on advanced stage melanomas. So advanced stage melanoma patients, that is stage 4 patients, usually survive less than a year. But now with immunotherapy, we have patients who have survived and have almost been cured of their disease, and they are surviving beyond a decade. Now this is something which is marvelous and only possible because immunotherapy has been able to do this. And the similar landmark in the treatment of lung cancer and renal cell cancer has been also possible with immunotherapeutic. Now, one thing we must all understand, that not all patients will be benefited from immunotherapy. It's not like the all or none law. That means if you give immunotherapy doesn't mean that it should work in all the patients. So we need certain biomarkers. So 1 in 10 patients, we say if we give immunotherapy to 10 patients, 1 or 2 patients will probably respond to immunotherapy and will be long-term responders. It is usually seen those who respond keep on responding. Those who do not respond, they do not respond. So how do you decide which patients are going to get immunotherapy? So there are certain biomarkers to decide whether immunotherapy will work or not. As of now, we are still doing a lot of research on these biomarkers, but in clinical practice we use something known as the immunohistochemistry, or the expression of the PD-1 or PD-L1 on the tumor cells or on the immune cells in the surrounding tumor microenvironment to decide. So if someone has a high expression of PD-L1 or in the tumor microenvironment or on the tumor, we would usually prefer immunotherapy. Similarly, another biomarker is the microsatellite instability. If someone has a high microsatellite instability on their tumor tissue or in the blood, we would probably like to give immunotherapy in these patients. There are other biomarkers like clinical parameters and others which need to be decided before we plan immunotherapy. Now coming to the toxicities of immunotherapy, mind you, all of these drugs, they are toxic. So they have been tried in clinical trials and found to be safe. But out of 10 patients, 1 patient will definitely develop some complications of immunotherapy which are usually low grade and self-limiting. Unlike the chemotherapy, which has a lot of side effects like loss of hair, mucositis, mouth ulcers, diarrhea, these are not the common side effects with immunotherapy. Usually you won't see any alopecia or mouth ulcers with immunotherapy. However, certain immunotherapies cause autoimmune disorders. As I said, the principle is to boost the body's immunity. So if immunotherapy is given, there is undue improvement in the body's immunity so that it kills its own cells, the body's own cells. So that is known as autoimmune disease. So you can have autoimmune pneumonitis, thyroiditis, you can have vitiligo, you may have dryness of the eyes, thyroiditis, endocrine problems. All of these things need to be taken into consideration while prescribing immunotherapy. Most of the time the medical oncologist, they will periodically check the patient's blood parameters to see if they have developed any immunotherapy related toxicities. Cost of the therapy is very costly. Immunotherapies as of now, these are not yet generic. They are manufactured by few pharmaceuticals and as such they are very costly molecules. Although they are a patient support program, still we should be giving immunotherapy to the appropriate set of patients. To summarize, immunotherapy has been a huge revolution in the treatment of cancer patients. However, not all patients will be benefited with immunotherapy. Essential is to identify the biomarkers so that we can treat the appropriate patients with immunotherapy. Immune-related adverse events may develop on immunotherapy, so the medical oncologist and the patient must be very vigilant to see that the immunotherapy-related side effects are addressed. Thank you.